Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Dr. John Holcomb. How are you doing today?
Great, Dennis. Great to be here. Great to be back.
Yeah, I appreciate you coming back. I was kind of surprised. But today we're going to go over one of the papers you helped get published from the Ukrainians on morbidity and mortality associated with ischemia-reperfusion injury after prolonged tourniquet use, a wartime single-center treatment algorithm. That's quite a name.
Yeah, pretty descriptive.
Generally states everything about it. Yep. Normally I would be here with Alex Merkel, but he abandoned me to go run around in the mountains in West Virginia. So I appreciate you, Alex. But starting off, I guess, why are we even doing this study? Like, what was the original question that we had that we decided to do this study?
You know, Dennis, we've done a series of studies with our Ukrainian colleagues over the last couple of years. And, you know, I've been really fortunate to be in Ukraine multiple times and have established pretty good, and many others have established some good relationships at all levels of medical care in Ukraine. We have published the Ukrainian experience with tourniquets, that many of them were not needed. And that there was very little conversion and replacement going on. We published, here are the patients with pictures who did not need tourniquets, right? So many tourniquets were run who didn't need it, up to 50 to 75% of tourniquet applications. In hindsight, and they get back, to a battalion aid station or stabilization point, they call in Ukraine, or a forward surgery team, in hindsight, were not needed. And so we've worked with those guys with that. We've worked with conversion replacement of tourniquets. And then you become, okay, now you do all that. Now what happens at the forward surgery team when a guy comes in, he's had a tourniquet on for a long time? How can we mitigate that ischemia-reperfusion problem leading to dialysis, an overload of potassium, lysed hemoglobin that comes up and kills the kidneys and can kill the patient very, very quickly. So this really focused on that small group of patients, not the guys with an obviously dead leg, and not the guys with minor injuries who had a tourniquet on for 30 minutes and you take it right off and they just drive on, right? So it's that middle group that we asked our Ukrainian colleagues to help us focus on and learn from, so that I know it's kind of a long-winded answer, so that we can change what we're doing in the US, NATO, TC3 world, right? And learn from the experience with LISCO and apply that to our system of care.
No, and that's great that we're allowed to get that information so that we can learn from it. We say it all the time, gathering lessons learned are so important, but so infrequently do we actually learn from them.
Yeah, we got to learn from them, right? We have to learn from those lessons.
So if you wouldn't mind, would you help me walk through some of this inclusion, exclusion criteria to get to that small group, that small cohort?
Yeah. So I think it's number one, just look at the numbers. One forward surgery team over 9 months. I mean, what was the number? 1,900 patients or something like that.
Yeah, 1945.
Yeah, 9 months. It's a pretty big number for a small forward surgery team. I know those surgeons that were at that team. They're very, very good. They're very well trained. We've interacted with them quite often in our meetings up in Poland. And what we asked them to do was to help us figure out this middle group. Again, not the minimally injured, rapidly there are some patients who come in very quickly, right? Because they're very close to the front line, within a couple of kilometers. And then there are patients who tourniquet on for 24 hours and obviously dead leg. And we're not talking about them. There's really unfortunately, no questions about those guys. It's the middle group. And we said, please educate us on this middle group where it's not exactly clear what to do, right? And that's what they did. They pulled that data out.
So obviously we're not talking about anybody that's has been shot through the box, or there's a real problem with resuscitation, or the leg has been, unfortunately mangled beyond repair for whatever reason, some kind of minor injury, we can either through vascular repair, shunting, ortho, we can rebuild him, right?
Yeah, Dennis, it's exactly right. So we all know about the life over limb thing, right? And so these weren't the patients who have horrible head, neck, chest, abdomen injuries, right? All up and down kind of the center. They're not those patients who are being massively transfused with other injuries. These are the patients, and they may not have isolated extremity injury, but they're not hemodynamically significant injuries other places. And the surgeons have decided to try to save this leg. So it's the group where you try to, now what's interesting is it's a small group, to your point. It's a small group. They have decided to save the leg in a small group of patients.
Yeah. So ultimately they came from that 1945 down to 74 remaining, that the life was stabilized. Now we're going to go with that extra mile and see if we can reduce morbidity and give this person at least a chance at a better quality of life.
Correct. That's right.
So one thing I thought was very interesting, step back. So they get this, one of the 74 patients, I guess, how did they, other than there's no shot to the box, etc., how did they assess this limb to say, hey, this is worth it. We can do this.
Yeah. So, they actually talked about this. So they had the 4 C, we're all taught those 4 C's, color, contractility. Can't remember what the other ones are, but we're all taught
cap refill.
Yeah. Consistency, right? That actually comes from World War II, World War I, World War II. And, you make a little incision and you look at the muscle, and they also talk about if the leg is stiff and contracted already, like the joint doesn't move. So if that leg is dead and doesn't, there's not good color, there's not good consistency, the muscle is mush, there's not contractility. By the way, that's not with a bovie, that's with your pickups, right? So you squeeze and the muscle contracts, not with a bovie, because dead muscle will contract with a bovie. It was taught to me by a surgeon from Vietnam when I was a resident. You do those things and you say, okay, well, the leg is either alive or dead. And that's what you do. There's no test. It takes about 10 seconds to do. And with the volume of patients that they're taking care of, you need to move very quickly with this decision process. It's kind of a yes/no thing. I as a surgeon who's done this, I really appreciated that discussion in the paper. To me, that's guys who really, really are doing it. They know what they're doing. They do a lot of it, and they do it quickly.
Yeah. And with that patient load and probably routine mass casualties, the longer you are hanging out in the OR trying to make a decision, the faster patients are building up behind you.
Somebody dies while you're waiting to figure that out, right?
One thing I thought was interesting, so while they're doing the 4 C's, patient still has a tourniquet on because they're trying to reduce the need for blood transfusions, which I think is very smart. I guess, so they're going by color consistency and some kind of contractility, because you shouldn't be getting any capillary bleeding from this.
You still will. There's still, even though you have a tourniquet on, there's still collateral flow that comes into the leg a little bit. Obviously, hopefully if you have a tourniquet, hopefully it's an effective tourniquet that stops arterial inflow from the femoral artery, but you're still going to have some, and you'll have some capillary bleeding as well. What they want to do is leave that tourniquet so that you don't exsanguinate through that leg, right? You don't want to have really big bleeding, because blood blood is a scarce resource, and every FST, especially one that routinely sees 100 patients a day.
Which kind of led me to the other question I had, is those same patients, 100% had compartment syndrome, which is crazy to me, because I thought, and I could absolutely be wrong, if you had an effective tourniquet where you have no distal pulses beyond that tourniquet, you should not be getting compartment syndrome.
Yeah, It's interesting. It's a great question. And I had exactly the opposite response. And and this is the value of, I say medics, writ large, right? And surgeons and ER docs all working together on these problems. For me, as a surgeon who's taking care of injured legs that have major vascular injuries, both with and without tourniquets, military and civilian, if we teach our surgery residents and anybody who rotates on the surgery team that if you have a major vascular arterial injury and you don't get revascularized in 2 to 4, maybe 6 hours, then you're going to have compartment syndrome, and you do when you reperfuse, and you need to do prophylactic fasciotomies. So when I read that, I'm like, well, yeah, of course. And it's to me, this is the dialogue that's been going on at TC3 for almost over 20 years now, which is really valuable. And you put these different groups together, they have different knowledge base.
Yeah.
Is the betterment of our casualties, by the way, in my opinion.
So that also makes me think, if I can't use distal pulses is to determine if I have a good tourniquet or not, what should I be doing?
Yeah, distal pulses is good. When we first started doing research in tourniquets back in 2003, at the ISR, we started writing those first papers. Distal pulse is fine because you're not going to have major bleeding, right? You have oozing. Like when you put that tourniquet on, you've done that, and you put a dressing on the wound, it doesn't stay white, right? I mean, there's still oozing that happens there, even though you have an effective tourniquet that's cut off the pulse. I got no problems with putting the tourniquet on until you cut the pulse off.
Okay, perfect.
The guy's not going to exsanguinate from that. He won't, but he will turn that white dressing red. You know that.
Yes. To be honest, I thought it was back bleeding coming from the distal side.
Yep. Good. Yeah. Or from those collaterals that go around the hip. I mean, there's the textbooks make the arterial supply and the venous supply look very uniform and regular. It's not. It's everybody's got a little bit different variation on that.
I also study from coloring books, so we can't blame it all on the anatomy books.
They're the same way. Yeah.
But so another thing that I mentioned, so that tourniquets on, they're assessing for compartment syndrome. 100% of them had it, and they did a prophylactic fasciotomy. And I'm assuming during that fasciotomy, once they've exposed the muscle belly, that's when they did their assessments on is this viable or not.
Well, no, the assessment was, do we need to revascularize the guy? And if they tried yes, then they'll do the fasciotomy and put a shunt in or repair the artery, whatever needs to be done to stop the big bleeding. If the assessment of the muscle that the leg is dead, those 4 C's, then they leave the tourniquet on, send the guy to the level 3 and let them do the amputation there.
All right, perfect. So for that assessment, would they just, I mean, eventually you're going to have to expose the muscle if it wasn't exposed from the injury. So are they making an incision, or are they just going through the actual wound and testing?
I've been making a separate incision in the non-damaged muscle. You've seen these. I mean, everybody's seen these wounds. They're big and they're nasty. The muscle there is damaged and not viable, right? It needs to be debrided. There's mud and dirt and all this stuff in the wound. So I would incision. Actually, you can either do it laterally in the thigh. You can do it on the calf. I mean, these incisions are this big. You go down and look at the muscle, make a decision. But I would do it in an undamaged area by the whatever the injury is.
Okay, that sounds good. So they make their assessment. Okay, they have compartment syndrome. That is a viable leg. Now everybody kind of holds their breath because they know as soon as you take that tourniquet off, all hell is going to break loose. So obviously we are going to be dealing with some kind of reperfusion injury, especially now that we've opened everything up. With the fasciotomy, there's no tension in that leg anymore to hold back any of the cellular debris. Yeah.
Yeah.
Evil humor. Exactly. So if you could, would you mind walking me through what they did to assess and treat for a reperfusion injury?
Right. And so this is where in the paper they talk about the surgeon and the anesthesiologist really working together, right? In our system, it would be the surgeon and the nurse anesthetist, orologist, whichever. They really don't have CRNAs. But you have, and you go, look, I'm getting ready to release the tourniquet. And the anesthesia person goes, okay, well, we're going to give, bicarb or calcium or lidocaine or theophylline or whatever the magic juice is, or is it just crystalloid? To the first step is to worry about the potassium load that comes out of that leg, ischemic leg. That's what causes the guy to die and can cause him to die in the next 1 minute, right? So that's very quick. Now, if he doesn't die then, and obviously you know about that. So you loosen the tourniquet. You don't rip the tourniquet off, right? You loosen it. If you need to put it back on, you can put it back on. So we used to do that I'm old enough where we used to do open aortas, right? And make an incision from stem to stern, cut your aorta in half and put a Dacron graft in, replace your abdominal aorta. And it's the same thing. When you release, after you sewed it in, you would release the clamp. You wouldn't release it like this, right? All the way. You would take it one click at a time and let that stuff come back in the systemic circulation and let the anesthesiologist deal with it. And then take another click, so that the hypotension that occurs when this happens can be treated, can be mitigated with volume or different drugs to mitigate that systemic insult that comes out of that ischemic leg, right? The systemic insult that comes from the ischemic leg.
Right. Now, they mention using crystalloids. I think they mentioned normal saline specifically, but I would imagine a wet crystalloid if you're in that kind of environment, and raising urine output from 100 or 100 to 200, somewhere in that range.
Yeah.
That doesn't happen quick.
No, it doesn't. Go ahead. I'm sorry.
So I would imagine we need to get this rolling before said surgeon removes this tourniquet, because he's got stuff to do.
Yeah. Yeah. I think this specific cocktail that they've reported has great outcomes. But as anybody who kind of works with crush syndrome or ischemic leg knows, there's like 1,000 different algorithms for how to do this. They're all focused on decreasing the acute kidney injury, right? The injury to the kidney. Getting the urine output up, maintaining a good urine output, not having the hemoglobin crystallize in the glomeruli and causing a renal failure. Now, I may not agree with some of the details of this personally, but it's hard to argue with the results, right? The results are that the tourniquet duration, if you look at their data, did not correlate with the incidence of AKI, acute kidney injury, which is interesting. And they only required between 1 and 3 days of dialysis at level 3. So that's pretty huge, actually. And it's one of the main things that we wanted to learn is how much dialysis is needed for these guys that are coming back. And the answer is not much, right? Now, I think that's huge, irrespective of the details of what they gave. Now, I would also say that, when you publish a paper, it's been in the works for about a year because it takes a year to publish stuff. I'm wondering about this for a while, and one of the research labs at USUHS, the Uniformed Services University of Health Sciences, USUHS, has started a research project based exactly on this question: what is the best way to mitigate the metabolic consequences of prolonged ischemia? And they're doing that work right now. So, I have a research project. We have these data, and we'll put the two together.
And I think, as far as dialysis goes, I know they said between like 4 and 5 hours. Like the shorter period of time the tourniquet was on, the more infrequent the need for some kind of dialysis. And I want to say it's a longer 8-hour plus patients. I'd have to look at the number real quick, but I want to say it was 8 hours. Yeah, greater than 6 hours. Sorry, greater than 6 hours. They're the ones that needed some kind of continuous dialysis, which I think makes sense. So the bigger the insult, the longer you're going to need to get it off.
Yeah. 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 Very interesting. Yeah. The tourniquet time didn't correlate with some things and did with others, right? So
I do not have a dialysis machine, nor should anybody trust me with a dialysis machine.
Yes.
What I can do is just at least hopefully stabilize this patient. I have crystalloids. I have calcium. I can get my hands on sodium bicarb. Like if somebody tells me I need it, I can get my hands on it.
I think this is just this, from a prolonged care point of view, this is a problem that hopefully that we want to avoid. Right. And this, I'll go back to my initial comments on conversion and replacement. This will happen in our force. There's no question in my mind. If we get into a LISCO environment and with denied airspace and drones and, all these things that our Ukrainian colleagues are teaching us, then we will have this. But in my opinion, and this is my opinion only, if you're trying to put a tourniquet on, you should be trained to convert or replace it. And everybody should do that. That will prevent 50 to 75% of this problem. 50 to 75% of this problem can be prevented if we teach that. And in my opinion, I taught my high school daughter to do this. She's taught Stop the Bleed. She's not a medic, although she started her EMT training in about 3 weeks, right? So she's pretty excited. Yeah. But we taught her to recognize who needs a tourniquet, who doesn't. We taught her to recognize, when patients need bleeding, when they bleed, when you try to convert or replace it, and when they don't. And, I think we can do that with most people.
I think you're right now, when we don't have outright wars going on. I think you're absolutely right, because we have time.
We have time. One of the papers that we wrote about conversion replacement from Victoria Kovacs, and she said, and I quoted her in the paper, it says, "Train now. You can't do this. You can't do this in the midst of all-out war." Right? It's not possible now.
And that's kind of my point. I mean, we're watching Ukraine suffer through this. We used to teach their medic courses to them, right? And we had all the time in the world after 2014, right? War has a funny way of truncating all of your courses, especially when attrition starts happening. And yes, absolutely. If that's something that we need to do, then we had better start doing it, because it's not going to get easier once it happens.
Train not to put the tourniquet on for minor wounds. And if you would put one on as soon as you can, easier for me to say because I don't do that job, but as soon as you can, try to convert and replace it. You'll be successful 50 to 75% of the time. And we can avoid the high and tight amputation for the extremity that didn't need it, right?
Yeah. I didn't ask you this earlier, but this study happened over 10 months, and you got to see the raw kind of data on this. Did you see any change in frequency or et cetera in the winter months? Because guys are wearing more clothes. Things like finding the injury is going to be a little bit more difficult because you're wearing 2, 3, 4, 5 layers of clothing.
Yeah, I did not. I'm not. It's a great question. Much like our data for what exactly happens on the battlefield versus level 2, role 2, very difficult to tease out some of that stuff. those are nuances of data that, frankly, I don't think that we have from Ukraine. They have the same problem we do, about the same rate of pre-hospital data, about 5 to 10%. And it's a great question. I don't know the answer to that question. We can ask that.
Yeah. I'm just out of curiosity, but just having done T-Tri-C, it's not super easy when a guy's wearing one layer of clothing. It gets a lot more difficult when they're laying, they're trying to stay warm in the winter.
There's less activity on the battlefield when it's really cold, and so it becomes a numerator and denominator thing as well. So there's multiple things happening there. There's temperature, and then there's an increase in drones and different kind of drones, right? The fiber optic drones have changed everything in the last 6 months from Buckers or these guys. And so you got different drones, you have different temperature, and then you also have, honestly, different areas of the battlefield, right? And different training and different elements of the Ukrainian. It's not a homogeneous force, right? Across the front line.
Yeah. Kind of the last question here. You're king for a day. You get to decide how we're going to train our medics or anybody's medics, personnel. How are you going to change T-Tri-C to address this issue? How would you do it?
Yeah, I would. I've said it before, and I'll say it again. I would really emphasize the conversion replacement. I think anybody who's trained to put a tourniquet on, which is now the entire force, right, appropriately, should be trained to convert and replace. And we need to and do that training. If we can train my daughter to disassemble and clean her weapon, we can train these guys to convert and replace tourniquets. It's easier than that, and it just needs to be done. The savings on the other end, mentally and physically, of avoiding. Just imagine if you could avoid 50 to 75% of the amputations.
Actually, sorry, I lied. It's the second to last question. This is the last question. So, we're teaching guys to convert tourniquets into a pressure dressing. Makes absolute sense. Tourniquets, like I incorrectly stated before, I would assess with a distal pulse. They have no pulse. Tourniquet's effective. We move on. X period of time later, I'm going to convert that into a pressure dressing. I place the pressure dressing. We pack it. Everything is beautiful. Somebody come take a picture of this because it belongs in a magazine. When I release that tourniquet, the distal pulse comes back. I have effective pressure dressing. Am I not also predisposing this patient to developing a compartment syndrome? And should there be a timestamp on that as well?
Yeah, I think it's a little bit of a complicated question, Dennis. In my opinion, Kevin, kind of watched this tourniquet evolution over the, last 30 or more years. Pressure dressings really aren't, right? They often fall off. If you put them on a upper arm, they come to me around the wrist. You put them on the thigh or upper calf, they come to me around the ankle. And that's because of the geometry of arms and legs, movement and etc. By the time, you put them on, by the time they come to me. That's one of the reasons why we moved away from pressure dressings into tourniquets pre-hospital, because it's really important to have hemorrhage control. And it's really hard to put on a good pressure dressing and maintain a good pressure dressing. And that's after a lot of work with a lot of medics, both military and civilian. That's not a negative comment on the medics. It's just it's kind of an oxymoron, pressure dressing, right? I mean, most of them aren't. So, and the ones that I've seen, are arterial tourniquets. So you can wrap that elastic or whatever dressing you want. There's many versions, tight enough to be an arterial tourniquet, and then it doesn't move. but now you got an arterial tourniquet, right? With all the questions there. So, I think if I was doing it today, I would probably convert with one of the hemostatic dressings that kind of sticks to the wound, and then put a non, I wouldn't. Easier for me to say, hard to do, right? I put a thing over that to kind of keep dirt and stuff out of it, but not try to put a quote pressure dressing on.
Oh, so essentially change from a tourniquet to just a dressing.
Yeah,
just straight up dressing.
If on the U.S. forces, I would have a hemostatic dressing in the wound, right? Pack it with gauze, put it, loosely put an not loosely, but tight. So
it's not so easy, is it? Yeah.
Yep, right. Not too tight, not too loose. Do it, please. Just do it. That's right. That's right. We laugh on pizza surgery resins. Will you please just do it just right? Yeah. But your point is, you can make a pressure dressing a tourniquet. We don't want to do that. You also don't want to have the dressing end up at the ankle or the wrist when they come into the roll too. So good hemostatic dressing sticks to the wound, pack it with gauze, wrap an ACE around it, and then watch and make sure it doesn't rebleed, right? Reassess. We didn't use that word once in the last 30 minutes, but we certainly need to.
Constant reassessment. And tell me if I'm wrong, if there is any rebleeding from this and my dressing is not effective, I can put the tourniquet back on.
Absolutely.
Stop the bleeding and readdress it.
Yeah. Yep. Absolutely. Yeah. And in my experience with taking tourniquets off, and I've done it a lot in the ED, civilian ED, and in Baghdad, right? And other places in Iraq, taking tourniquets off, you'll know it right away. You pick the tourniquet off and bleeding. my first tourniquet, I took the tourniquet off and the blood hit the wall, like, holy shit, better put that thing back on. Yeah, that's my experience. It's a yes, no kind of answer.
Yeah, definitely. The first tourniquet I watched a provider take off, he used a pair of trauma shears and just cut it off. And then I had to go dig out some more.
The other one. Yeah, and anyway, wish I hadn't done that. Yeah.
Now, promise, last one. Does that reset my tourniquet time?
Yes. Yeah, to me, it's somewhat cumulative. Well, I mean, the real answer is don't know, right? Yeah. But I would make those additive because you got, that ischemic damage to the tissue.
Sure. So maybe revisit this in 45 minutes?
Yeah.
That should be plenty of time to, assuming you're in a safe place, to have built a clot, I would imagine.
Yeah. And, there are not many hemostatic dressings like what we have in the U.S. military. They're too expensive, what I hear from most of the Canadian forces. And so we got a little bit different paradigm, right? So some of the hemostatic dressings are really good. So.
Yeah. No, definitely. Some of them are very good. Some of them, I think, depend a lot on clotting factors that are already present, or like the patient's own ability to make a clot is present in order for them to work effectively. Mm-hmm. Some work in different mechanisms. But I guess my kind of concern is for those countries that can't afford those things. I have just regular gauze. I have to almost, it's a very difficult situation because you have to take that tourniquet off with some kind of pressure dressing. Has to have just the right amount of pressure to do it. Yeah. And we have to somehow keep this in place, which is a trick in itself.
It is. But remember, most tourniquets that are put on in hindsight weren't needed. And so 50 to 75% of tourniquets, at least in the current data that we have, will successfully convert to a regular dressing. Just a regular, because they weren't needed to begin with, right? This is all in hindsight. So 50 to 75% will convert. Make it 25%, 50% are needed. And in my experience, you'll know that right away.
Yep, absolutely. Well, thank you, John, for listening to my ridiculous questions.
No, it's a good conversation, man.
I appreciate it.
Anytime.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.